First of all, very briefly, I would like to summarize what we discussed this morning. The topics were very interesting. Very seldom do we participate in conferences where only news are announced. So congratulations to the association for allowing so many experts to participate and share the new data. Now, this morning we listened to Dr. Passafaro, Dr. Parent. So we started from the experimental approach, so expression of proteins in the rat hippocampus, APS hypothesis. We listened to Dr. Parent, Dr. Compagnucci, and we heard about new understandings of the disease, and we also heard about new potential treatments. It would be interesting, in my opinion, to administer the drug to the APS of patients who have undergone a mutation. This would be electrophysiology studies. We heard about some genetic and clinical new data. Dr. Terracciano shared her experience on male patients, and this is a very important piece of information to be taken into consideration in the diagnosis and in the search for new cases. Dr. Getz shared his results on the assessment of allopregnanolone. Some results have already been published in his paper that was published a few months ago. And we also heard about the new estrogen receptor, which is, again, new information. Dr. Biagini's data on neurosteroids as promoters, endogenous promoters of epileptic seizures. We heard again about allopregnanolone, and we also heard about the possible impact on treatment. Dr. Petrova, rather, and John Sullivan both talked about this topic. And then we also discussed future therapeutical options. We heard about CBD. In the working group meeting we had yesterday, the assumption was made to develop a CBT trial. We're now going to discuss it together with the company. We're going to discuss the feasibility of a trial here in Italy using CBT on girls with mutations. And then Dr. Striano's data on alternative medicine and diet. So we have quite a lot to discuss: genetics, the clinical and therapeutical approaches. Now, since my co-moderators are Dr. Leguern, who deals with genetics, clinical activities, Dr. Higurashi has been dealing with therapeutical issues, and he published papers on steroids. Dr. Cusmai is an expert in the clinical field, in the field of phenotypes, and in the neurophysiological and electrophysiological field. Now, I would like to ask you all to comment, just a couple of minutes. Please comment on your field of activity, and this can trigger the general discussion. Raffaella, the floor is yours. Yes, first of all, I would like to thank the association and Francesca and all the people who are here today. Now, there are a few things that I would like to highlight. First and foremost, phenotypic characterization of girls with PCDH19 is quite clear in our centers. I would like to draw your attention to the males now. Well, of course, there are very few male cases. Now, based on my experience, the male phenotype is identical, similar to the female phenotype. Therefore, a diagnosis can be made at an early stage in both in boys who start having cluster seizures, especially in case of fever. And these seizures overlap with the ones that we recorded in children, girls suffering from PCDH19. Dr. Terracciano showed two critical areas. Can you remember her slide? There was a girl on top of her slide, and at the bottom there was a boy. Now, also the electroencephalographic features show that at onset the situation is not normal. You can see slow anomalies in the temporal regions, bilateral or unilateral, and if bilateral, they are asynchronous. In my opinion, characterization, paying attention to the diagnosis in a boy at his onset with cluster seizures, because again, this is the main feature. Seizures that from the electroencephalographic point of view are stereotyped and overlapping. And I think it was the case in one of these boys that he was scared, he was asking for his parents' help, expressing, voicing fear. So the affective component, as written and demonstrated by Carla Marini in her paper, and Professor Dalla Bernardina contributed to this paper. So we're talking about affective signs. The affective signs are present, and the manifestation depends on age. Of course, an older boy would say, I'm scared, and he will call his parents, while a younger boy will not be able to voice that. So we have to pay attention to boys, to male presentations who may suffer from the same disease plus B mosaic. Some participants in the audience and also the doctors, families, all of us together, we should focus on the therapeutical approach. As Dr. Specchio said, there are ongoing trials. Yesterday we heard some interesting data on ganaxolone, and we also heard about cannabinoids and alternative medicine, as in the case of Dr. Striano. So maybe we should be taking stock of the situation. Where are we up to with treatment? What about the trials? What are our impressions? What are the best medications, drugs to be used? And what about future steps and future developments? As far as genetics is concerned, I think I will leave the floor to those who are experts in the field.
Let's move.
Nice to meet you. My name is... And I'm mainly now doing the clinical work and see a lot of patients with childhood epilepsy. And I've been doing the research on epilepsy caused by the PCDH19 mutation in Japan. And unfortunately, the researchers in Japan this syndrome is only few, and I identified almost all of the Japanese patients. So anyway, I have to comment on the potential treatment of this syndrome. And today I really studied many new topics from many researchers, especially regarding the ganaxolone or neurosteroidal treatment that really fascinated me as a potential treatment in the future. And I'm really looking forward to getting the good results of the clinical trials. But the one thing I can definitely to say is many anti-epileptic drugs do not work well on this epilepsy. And as Dr. Stroyan lastly presented many other potential new treatment. But we can have many future potential treatment to be evaluated rapidly. But the main problem is the very unique appearance of the seizure. The patient usually seizure clusters, maybe during the most strong activity periods, the patients often exhibit seizure clusters almost monthly. But after that, the seizures in some patients, when the seizure clusters disappeared, after the disappearance of the seizure clusters, the long-term seizure-free period continued. In some cases, such period can be years, 1 or 2 years. That makes it difficult to evaluate the real efficacy of the one treatment. That is very difficult point to evaluate the real efficacy of the some treatment. So we should plan the that's a very difficult point, but the robust way to evaluate the correctly so the way to evaluate correctly of the treatment and the next steps. And sorry.
Thank you.
So I'm a geneticist, and I would like to come back on the molecular screening for PCDH19 related epilepsy. And I would like to underline that as for all the genetically determined disease, the molecular screening is crucial for PCDH19 related epilepsy. Indeed, I see 3 reasons. The first reason is the genetic counseling. In familial forms, you can predict the risk of recurrence in the family, since the mode of inheritance is autosomal dominant, as you know, with about 50% of risk from one generation to another. And this genetic counseling is more complex when the case is sporadic due to a de novo mutation. I would like to remind you that de novo mutation corresponds to a mutation identified in the young female patients, and you don't detect this mutation in both parents. But you know that there is a risk, which is low, but a risk of germinal mosaicism in parents. And I think that all parents with a young female patients with PCDH19 mutation have to be followed in a genetic counseling service. Indeed, the risk is not very important, but we can provide to this couple a prenatal diagnosis to confirm that the fetus is normal. So I think that genetic counseling is at the center of our reflection in terms of genetics. The second reason is, as you said, the occurrence of mosaicism in male with a phenotype very close to the female. And I think it's a new avenue for our diagnosis for PCDH19 related epilepsy. And it's a very difficult question. Science, if we performed molecular diagnosis also in males, I think it's a very huge amount of work for our laboratories. And so I think that the technology have to be diffused in many laboratories in Italy or in France to be capable to perform this diagnosis both in female and in male. But I think that the clinical screening will be crucial before sending the samples to a molecular laboratory. So this is the second reason to perform a massive molecular screening of PCDH19 gene. And the third reason is a treatment. Indeed, we saw this morning that to conclude on the efficacy of a treatment, we need a large cohort of patients. And this is why I think that one of the missions of clinicians, geneticists, and also patient associations is to have some registers with the mutation and with the phenotype to perform very, very strict therapeutical trials. And I think it's a condition to perform good therapeutical trial. And in the future, as Joseph said, there will be the precision therapeutic based on the mutation. So this is why I think that all young female patients with this phenotype, with recurrent clustering of seizures, has to be analyzed for the PCDH19 mutation. And finally, I would like to underline that we know perform a molecular diagnosis, so we know diagnose. But for us, it's not possible today, and it's very frustrating, it's not possible to provide a prognosis to parents. And I think it's an open field of research for the future. And for example, to well study the distribution of X inactivation in different tissue, to extrapolate this X inactivation in the brain. Okay.
Okay, thank you so much. Thank you. Okay, ci sono domande
Are there any questions from the audience? In the microphone, please. In the microphone, please.
Un attimo, serve il microfono per la traduzione.
Ecco, diciamo
This is not closely connected with what you said, but unfortunately I have to leave in a moment. So I would like to ask you, the researchers in the field, now among alternative therapies, what about ozone therapy? In my opinion, it's very good. For my daughter, I tried many different things, different medications, anti-inflammatory medications, anti-epileptic medications, vagal stimulation, homeopathy, and so on and so forth. And I can say that ozone therapy, in the past we used it we did it as transfusion, but it was a bit difficult because my daughter has vein problems. Now we're using the intestinal form, so they insufflate ozone into the intestine through a catheter. And it seems to have a favorable impact on her, not on the seizures, but I would say especially on her level of attention, concentration, the ability to stay focused, her vitality. And this technique is associated, it's used for many neurological conditions. And I know that also other people use it to treat the epilepsy, or for Parkinson's disease and other neurological degenerative conditions. Of course, you cannot do it for a short period of time. It doesn't work if you only try it in the short term. In fact, it can be even more, it can be dangerous rather than helpful in the short term, because it may develop, it may cause withdrawal when you stop it. But if you use it in the long term, it can give you a favorable effect. Thank you very much for your question. Personally, I have no experience whatsoever concerning this topic. Does any of you have any experience? Do you want to comment on that, ozone therapy? Pasquale, what about these alternative treatments? Do you know anything about ozone therapy? In the microphone, please. Do you have any data? No. Any of you? Do you have any experience? Do you have any data concerning ozone therapy? Comments? No. Well, then this is something that we need to study in greater detail. I do have a question. Since we're discussing different types of treatment, I have a question for Dr. Higurashi. Now, concerning the use of steroids in acute phases, I mean, the use for long-lasting clusters in the disease. In your opinion, what are the mechanisms whereby the efficacy is so high in your patients?
So, in my opinion, actually, I'm not sure about the underlying mechanism of such rapid, immediate efficacy of the corticosteroid that can suppress the seizure clusters. But as far as I know, many papers say that corticosteroid itself act on a neuron as excitatory. So because the corticosteroid can induce the increased expression of calcium channel. Calcium channel induce the excitable change of the neuron. But definitely, in many epilepsy syndrome, corticosteroid works well as an anticonvulsant. So, for example, West's syndrome and Lennox-Gastaut syndrome and CSWs or many other intractable epilepsy diseases. So that indicates that the efficacy of corticosteroid in human being is maybe act as a anticonvulsant drugs. So I found that in this disease, the PCDH19 related epilepsy, the efficacy of the corticosteroids appeared very rapidly after the administration of corticosteroid. So that let me speculate that the main point might be existing in the BBB, blood-brain barrier. Blood-brain barrier is a contact point between the peripheral and the central nervous system. And so the patient often showed the recurrence of the seizure clusters during the infectious period, during the fever. So I speculated that there's some kind of systemic inflammation could induce the seizure recurrence. So the BBB may be the point because that is a contact point between the peripheral inflammatory changes and that affect to the central nervous system. So corticosteroid has one major action on the BBB, that corticosteroid increase the barrier function of the blood-brain barrier. So I just speculate that the efficacy, the underlying mechanism of the rapid efficacy of the corticosteroid may the restoration of the blood-brain barrier permeability.
Thank you. Other comments?
Yeah. Do we know whether the corticosteroids act rather on inhibitory or excitatory neurons? Interneurons or pyramidal neurons?
Maybe many papers investigated using, are mainly looking for the pyramidal neurons. Excellent.
Domande?
Questions? Dr. Brambilla? Hi. I am a mother. I don't know if this is the right time or if you want me to ask my question later. We would like now to ask specific questions on, and then we will allow families to ask their questions later on. Now we would like to focus on this morning presentations. So ask questions on this morning presentations. Dr. Brambilla first. Hi. You presented ganaxolone this morning. I would like to know whether for the Dravet syndrome you have any evidence. Could this be used as an anti-epileptic drug for the Dravet syndrome in the future? Thank you for your question. Officially, I can say that the trial on ganaxolone is now ongoing at Bambino Gesù and in other centers in the United States. And last week, we received the approval from the Ethical Committee to expand the case series. So starting from next Monday, say, we'll be able to enroll, recruit patients suffering from Dravet syndrome and children with epilepsy due to CDKL5 mutation. So the answer is the indication has been expanded. The trial will also be carried out on Dravet syndrome patients, and we will start, hopefully we will start recruiting in the next few weeks. Thank you.
So I have a question. I think it was Joseph who, I never thought about the mosaic as being able to be asymmetric in the brain. And since from a phenotype, we often notice these children have bitemporal or biposterior seizure onset, I wonder if there's any hypotheses as to developmentally why the mosaic may end up in this region of the brain. And a follow-up question to that is I have one patient. I never like to mention, draw too many conclusions with one patient, but an adult who we talked about yesterday who underwent a temporal lobectomy with a PCDH19 mutation and has been seizure-free for 5 years. And I just wonder if we were able to study that temporal lobe, if there would be something different in terms of the mosaicism of the cells, in the neurons in that lobe of the brain.
Eric, this is for you.
This is for me, but I have no answer. It's very complicated. Do you think that from a developmental point of view, the distribution of X inactivation is very particular in temporal lobe? It's your hypothesis.
No, my hypothesis is more why do many of these children from a neurophysiologic localization point of view tend to have seizure onset in the bitemporal regions? So is there something developmentally that may explain that?
I'm not sure that we can relate this localization with the distribution of X inactivation. We know that we have different genetically determined epilepsy with different focus, especially, for example, LGA1 mutations lead to a familial focal epilepsy, and we don't have any explanation for that. I think it's very difficult to relate the mutation to the epilepsy. And I think, as I said, it's crucial to identify the mutation. But we need a large panel of techniques to understand the different steps leading from the mutation to the epilepsy. And the geneticists are very frustrated because they identified many genes with many mutations, and it's difficult to relate these mutations and, for example, the expression of the gene with the seizure, with the type of the seizure, and with the localization of seizure. So today, I don't have any answer. Do you have any answer?
Well, I don't have an answer, but there is a possible answer, and we would need to have developmental biologists here. In that work of Jeremy Nathan's, when they tracked the structure of the X inactivation and patterns in the developing brain, they did notice that what Joe is alluding to, that certain structures of the brain will be more vulnerable to the variation in X inactivation than others. So one striking example was interneurons versus excitatory neurons. And when they looked systematically, they saw that if X inactivation and the stochasticity is going to affect more interneurons because of the pattern of migration than excitatory neurons. So it's possible that, of course, as a consequence, certain structures can have this focalized pattern of certain cells, and if PCDH19 is responsible for sorting of these neurons, so it's quite possible that those regions Joe referred to may have more sort of a defined clumps, which can be then producing the focal seizure, which I know from another case from Germany that was operated on because the girl had focal cortical dysplasia. They thought that the seizures originated from there. They surgically removed it, but unfortunately the girl continued having epilepsy, but it's what Joe mentioned. In that case, it seemed to have worked. So maybe they got the right region. So it's quite possible because during development and these cells, and we need to learn from it, may point us to the regions where we actually can start looking whether the seizures are originating. And I don't know, maybe even surgical procedures may have some benefit, but I'm not really the person to comment on it. But I don't know if, Joe, I answered your question, but I think there are clues in the development to the vulnerability of different parts of the brain because of, if it relates to X activation, at least.
E volevo fare una domanda a Joseph Getz.
A question for Joseph Getz. Did you measure the levels of cortisol? Did you measure the cortisol levels?
Marina.
Did you hear me? Did you measure the cortisol levels? This was the question for Dr. Getz. May I? We measured it. In the microphone, please. I'm sorry, we can't hear. In the microphone, please. No microphone, no translation.
Did you measure the allopregnanolone?
Avete misurato l'allopregnanolone anche nei maschi? No, non lo abbiamo misurato. Si tratta di un caso francese, non lo abbiamo misurato, ma io incoraggio fortemente voi qui in Italia a misurare e a testare i maschi con mosaicismo, perché sicuramente ci potrebbero dare delle informazioni utili, ovviamente se dessero il loro consenso. Per quanto riguarda il caso francese, anche in quel caso sarebbe bene fare un paio di misurazioni. Una misurazione non basta, 2 è meglio, 3 sono ancora meglio, 3 misurazioni. I think there's...
Going back to the previous question about temporal lobe and the possible specificity for an effect of these mutations on the temporal lobe epileptogenicity. I was thinking about the biological role of granulogenesis in dentate gyrus, since there is a slow, but there is a continuous proliferation of newly formed granule cells in this region. This could be maybe, I don't know if there are data in the literature or maybe unpublished or still unreferred data about that this normal process can be affected by this mutation. So it is debated the fact that an abnormal granulogenesis in the dentate gyrus, or also a defect in migration of these newly formed cells, can be really involved in producing epileptic seizures. But anyway, it could be worth to know if this mutation could affect this phenomenon.
Domanda dietro, professor Viggiano.
We have a question? No, rather two comments. One has got to do with what Raffaella Cusmai was saying about the importance of the phenotype. Most of all, it's important to have a better knowledge of the natural history of the patients. And this is in order to understand the possible efficacy of alternative treatments. Otherwise, we run the risk of taking away efficacy to spontaneous healing, which may take place only because the patient is developing. Siano was saying, well, let's pay attention because there are no controlled trials, and this is a possibility. And the second thing has got to do with the action of ACTH action. We don't really know how ACTH works. We've been using it for the past 60 years, even more. We started using it in 1956, so it's even more than 50 years. We know that it may have an anti-inflammatory action. We know that in a young kid, it favors neuronal migration and demineralization. It is true that it is active on some GABAergic interneurons, but what is fundamental is to bear in mind that ACTH works and sometimes doesn't work in all of the epilepsies, but rather only in some of them and only in given moments, in given stages. That is when the child is having the Lennox-Gastaut epileptic encephalopathy, or when he has spasms. But same child, if he has focal seizures, he gets no ACTH benefit. So this is a drug which comes with a very specific mechanism. The most credited therapy as far as spasms are concerned is that spasms are concerned because of a hormone-related change. There is a decrease in CRH, and ACTH may provoke and compensate for the hormone-related variations in the children. So it is acting only in that very given moment. So apart from spasms, the ACTH has no anti-epileptic action. So we have to make comparisons with hormone-related therapies. Let me say that this is absolutely true. But with respect to ACTH, in patients with epileptic encephalopathy, I know that many years ago, we had an intramuscular flebocortide and hydrocortisone. So cortisone therapies in pharmaco or drug-resistant epilepsies in case of acute disease have been used for many years. And the mechanism, apart from ACTH, the mechanism is still unknown. So I'd like to ask to the public and to those who work with PCDH19 girls, what, according to them, could be the clinical trials that were presented, the one with galaxolone, with a follow-up of 26 weeks, i.e. short periods, or cannabinoids, because we do know that the treatment is a long-term treatment. That is how long the therapy holds with respect to the therapy in a given child context. In a current situation, which is 51 Italian cases, some 86 that were referred by the French, and other cases have got to do with United States cases, which seem to be quite overlapping. What, according to you, could be the best therapy, if there is one? And we know that each one of us tries new drugs. The experience of the Bambino Gesù is that once the girls would end up in resuscitation units. Today, this is not happening to the same extent. So what, according to you, could be the anti-epileptic which is best with respect to the onset and with respect to the later stages? Because obviously there are crises which may be very much age-related. And we know that just like in other epilepsies, there is a natural course of the history of epilepsy. Let me just add one thing to your comment. It is true that in recent years, girls are with great difficulties end up in resuscitation units. It's very rare indeed. Now, the idea is not so much connected or due to the fact that today we are much better in treating because we have drugs that are different. No, because substantially the drugs are the same. Probably the reason for this is a twofold reason, because in the first place we are having many more diagnoses. We are diagnosing patients with a phenotype which is milder, and this is one where there is a very severe phenotype. Then in the second place, we've understood that the natural history of the disease. We now know what that is, and we avoid using too many medicines. We avoid prescribing heavy treatments, and many times we know that this is entailing an overload of drugs, which then in turn brings about a difficulty, even a respiratory difficulty in the acute stage. So nowadays we have diagnoses on patients that earlier on went undiagnosed. Thank you. Let me just stress what Nicola just said. It is not even easy to make predictions, but especially as far as the overtreatment with a single patient, which is to be avoided. But I was struck by the date that I myself presented out of the European case numbers, that is 58 girls that were using bromides with an efficacy which is equal to the one of clobazam. And then, obviously, that one is to be confronted with the tolerability data. So I'd think it twice before using bromides. Then the other thing that I wanted to discuss is whether you find yourself with the worsening of crisis, which seems to induce the use of sodium channel blockers, and whether you did notice something like that. Well, I was talking about this with Dr. Trevisano earlier on. The children cases that I know, many of them are monitored by Nicola and by Dr. Trevisano and by Dr. Vigevano. Well, I must say that the first drug that's been administered, at least this was the situation, was Tegretol, because the Tegretol and the crisis of carbamazepine was a focal type of seizure. So it was affecting the temporofrontal region and sometimes the lateral one. And that was coming with polyspikes, long polyspikes, and long seizures. So the first drug was Tegretol. Then the generalized crises or seizures are usually of a bilateral kind. Now, as far as I can remember, there were no girls that were aggravated because of the use of Tegretol. Now, the association and the study of early patients told us that when the seizure was recurring and we had some clusters, Tegretol was summed with Depakin. And Dr. Specchio, in the acute stages, was trying the clobazam, and it did produce good results with clusters, so much so that it was used in chronic acute cases. So as soon as the cluster was started, that was used. And its use or input, and here I must say that I also do behave in the same way, because maybe for the first 2 or 3 days is been given, then afterwards you little by little discontinue the drug, which is what generates good results. But the worsening of the patient condition because of Tegretol, I don't remember. Lamictal in our own patients was never used, as far as I can remember. And we've had the patients taking levetiracetam, but in 1 or 2 cases there was a big effect that was induced as far as the behavior is concerned. Now, the drug was not so much effective as far as seizures were concerned. The treatment period was also not that much long. So substantially, what we can say is that our patients have some therapies that are sort of standard on the basis of our own experience. But I do not remember the worsening of patients because of carbamazepine, neither younger patients nor older patients. And then I'd like to hear Professor De Bernardini's comment. As far as the overtreatment and the different therapies that were tried at onset, which is something that was very much reduced as opposed to past time. Well, many parents tend to ascribe the cognitive delay to this kind of stimulus because the different drugs entailed, in some cases, so many seizures, so much so that we now associate somewhat late the constant stimulus of the brain. And then sometimes we associate it to a specific drug, Topamax, Depakin. Now, I wonder whether you now have more data, further comforting data, that seem to be confirming this theory of ours. Now, since today the treatment has been reduced, was there ever a girl that did not show progression signs, but rather the contrary, and did it so rapidly? Now, quite certainly, the treatment nowadays is less aggressive from the pharmacological point of view, at least. And this is because of the fact that we know what the cause is, what the evolution is. And as to the effect of drugs, the effect that they may have been generating cognitive data or whatever, there are no data. And I do not think that... what about the data on outcome, Marina? I was looking at your own slides a few days ago, and they were showing the frequency of crisis and cognitive disorder. So patients that really had more crises had greater cognitive problems, but we don't know whether there is a correlation. There is no certainty that the crisis or the drug have been generating this cognitive disorder. And we don't know whether that is associated to a more severe phenotype. It's the same genetic mutation, which in some given children, it generates a more severe picture. And those girls with a less severe crisis, with more treatment, I wonder whether these girls could have a worse, much worse than before kind of outcome from the cognitive point of view. And as far as the cause-effect relationship, that is a crisis and cognitive item, we still don't have certain data. So we have to proceed in a very cautious manner. Professor Bernardina?
Vabbè, poi posso dirvi il risultato della nostra esperienza.
I can tell you what the result of our experience is. And we have to consider the number of subjects that we are sure having followed ever since onset for the entire duration of the rest of induction. Now, I'd like to ask all of you and all of those who took the floor this morning and all of those who have a good knowledge of trials to take a step backwards and to ask a question and try and give an answer to the same question. Now, I'm 70, and my memory capacity or memory function still is quite preserved. It's it is something that allows for many things. After some 10 years from the marketing of the so-called new generation drugs, it's the stock of epilepsy that are drug resistant and that are now. This doesn't mean that we haven't gone forward in our own knowledge, but we have to invent some trials different from the ones that are still being done. Because if you take a look at the modest sum, we see that 50% gets A, 50% gets B, 50% gets C. Now I wonder how many 50% do we have to obtain or have in order to have a 5% reduction? There is something that doesn't really click right here. Then genetics. Now the genetic method, the genetic analysis method progressed at a speedy pace, and we thought that that was the mechanism, or at least could be. Meanwhile, we've lost the use to put together phenotypes. And if the phenotype is exactly a varied one, then it's not enough to have the PCDH19 phenotypes if it's variable, as we know that it is. And then after that, once we know it's variable, we could stick that over time. So we don't have a 15-year-old PCDH and a 10-year-old PCDH, and then try and see what is the answer to the drug treatment. Now, in order to do something which is similar, what it takes is the ability to carry out some trials that are different, which is not envisaging a long, open method approach. There is always the cost-benefit that needs to be corrected. And it just can't come to a halt after some 20, 24 weeks. Do you want to know what are the dates? Who, just for the sake of making an adjustment, do you know that these drugs are not recognized anti-epileptics? They make everyone rich, even vendors of possible therapies, alternative therapies. So, in PCDH19, the main problem nowadays is the one of collecting, apparently, some 50 people if we have a trial. And if we have understood that we can't put together the ones aged 10 years with the ones aged 10 crunches, we want to know how the therapy wants to Now, I know that we have to consider the ones that are age 50. We have to consider some 50 cases, and otherwise we will have to shorten the pathway, and we have to consider the 50 different subjects. Now, are you astonished that the 50 different subjects have and yield 50 different results? No. Now, obviously, in order to answer to you, I must say that in the 7, 8 cases that I followed personally, and these subjects are aged some 14, 15 years, I believe, and they've been followed for the first and second year of life, I remember that initially they would produce cluster crises, and they were taking Gardenale. At that time, this is exactly what was used. And whenever they produced cluster reactions, they would have the flebocortide intramuscularly or intravenously, plus Gardenale, because I still think that cortisone has a function in reducing or inhibiting that self-maintenance mechanism which has been created in the very moment when there are recurring crises. So this is not something that affects the mechanism that generates the crisis, but rather self-maintains the disease condition, the disease state. And this is what happens. Now, I do remember years, maybe 12, 11 years, during which no more crises were generated. After that, the barbiturates were eliminated. Now this woman is graduated. She has a normal life. She has no disorders, no cognitive disorders. But if you want to create a phenotype, then you may have a personality which may be stiff, but she's rather normal, and she's having no seizures. Whilst whenever we stopped using Gardenale and we were using carbamazepine on given people, as Raffaella said, because the pattern was rather a focal pattern, I can't really say that the condition has grown worse, because that means that you have intervened after a sufficient time, control time, and monitoring time, in order to say that you are not in a situation where you have the worsening of a crisis. But with carbamazepine alone, I've never seen any kind of result in the period when the clusters were many. And in the moment when we started using N-tiracetam, some results were generated. And I believe that they were generated because there was an interruption of trends in the moment, the florid moment. And that was seen after many years. But we can't maybe, cannot we think of having a protocol maybe? And Nicola, the extension to Adrane is something, to the Dravet syndrome is useful. And the assessment parameters have to be different. And when we try cannabidiol by adding the Lennox syndrome and the Dravet syndrome, obviously, the more you increase the ones that are not doing fine, and the more you get some results. But you cannot really understand where and why it did work, because you're treating two different epilepsies with two different mechanisms, and the phenotypes are totally different. And if you add someone who develops 3 different seizures every day, more or less every day, and then you add someone
l'equivalente in totale
who's having an equivalent, total equivalent of a crisis in a month, but just simply does it in a week, some 30 seizures, and if you count then the number of seizures, then you get up with, and you end up with a datum that you will never use. It won't be of any use, because you won't ever understand who benefits more from what and when. And I believe that this is even more so from the viewpoint of scientific methodology. And here, let me say that this morning, when I heard his presentation on the state of disease that was induced by pilocarpine in temporal epilepsies, whenever we consider the temporal epilepsy model, if we consider the genetically determined epilepsies, then we see that you are confronted with the problem where both temporal lobes may be affected. And whenever I consider the mesial sclerosis, we know that there is a homogeneous population. We well know that some 30% of patients with temporal epilepsy of mesial cases has a dysplasia associated onto the same temporal lobe or contralateral lobe. Are we so sure that we have considered subjects that are taking same things? And whenever we consider allopregnolone, we've seen that allopregnolone was not dosed directly on the patients, but he was using the enzyme that inhibits allopregnolone. And I hope you can confirm or disconfirm this to me. But you can find different levels whether you measure it or not. You measure it some 5 minutes after the end of the cluster or 3 days after the end of the cluster. And if it's a month, maybe it's a month that they have had no seizures. So when someone is dosing allopregnolone in a given subject, if there are variables that are affected by the moment when you administer that, it's just like the evaluation of cannabidiol in the Dravet syndrome, where alertness and the presence from the cognitive viewpoint and the awareness from the viewpoint of the evaluation, depending on the fact that the last crisis took place some 1 week ago, or 1 week before, or some 20 days before. Well, this is what changes the protocol. The geneticist and the clinicians somehow should sit around the table and see how to redesign the trials that have been verifying the results obtained, well knowing that the more you target a well-defined phenotype, and the more you will need the fact that trials are going to be multicentric, because otherwise you don't have sufficient numbers. And if you reduce them, you will increase the lack of homogeneity of the population and the very poor ability to practically translate everything into the clinical daily practice, all of the results of the trials, because nothing has changed in the end after some 20 years.
Let me clarify something Professor Della Bernardina said. Having a trial, having a study on any medication, be it a cannabinoid, ganaxolone, or anything else, emitiraceram, without considering the phenotype and the age, it would be useless, because if you have a 10-year-old Dravet patient, that's different from a 2-year-old Dravet syndrome. If a girl is 13 years old and she has a different phenotype, and by phenotype I mean electroclinical features at the onset, And we know that these features change in time as the patient's age changes. So we start from a phenotype, such as fever, clusters, electroencephalograms, but of course they do not remain unchanged in time. So the age is an important factor. So combining a 3-year-old patient with a 12-year-old patient, that means having no clear understanding. Moreover, in PCDH19, in the Dravet syndrome, and in other types of epilepsies, there are 2 variables. Both, of course, have specific disease states, and both have individual seizures. Now, when you perform a study and you say the response was higher than 50%, this is the case if you have monthly seizures in a more homogeneous population, if you consider, for example, bilateral pachygyria and other malformations. But seizure reduction means interruption, discontinuation of the disease in both medical conditions. And this is a very important factor because for the child, for the family, for the parents, for the brain, maybe the reduction of the number of disease states. If you go down from 4 to 1, or if you have individual seizures only, that's already a remarkable result. And that has been the case in some patients I know, using ostoribantol for Dravet syndrome. Maybe the efficacy was not related or was not associated with a number of seizures or chronic epilepsy, but for sure there was a reduction in the number of clusters, which can be a very big problem. So age is an essential criterion in a nutshell.
Sì, sono assolutamente d'accordo.
I fully agree. I agree on the idea of trying and propose trials on a homogeneous group of people, especially in terms of age, especially when there seems to be a variation in the trend of the disease, meaning seizures associated with age. This is a very important point for discussion. Joe?
I also agree with everything that's been said. However, the question I would have is, do we really think that there should be a reason why a child with Dravet syndrome, since that's the example that is 5 years old, would respond differently to a medication than a Dravet syndrome children that is 12 years old, understanding that the phenotypic features of the child at that age are different. But in a trial that lumps them all together, and that's why we use their own baseline as the metric by which a percent reduction, do we really think that there would be an age-dependent difference in how these children respond to drugs?
Sorry, are you saying that, can you repeat the last part of your question?
While it would be perfect to have a homogeneous phenotype, not only based on genetic diagnosis, but based on seizure semiologies at enrollment, I just question whether, does that give us an increased chance of detecting whether the drug is effective, as opposed to the mechanism that we use now. Because what we're saying is that you have to have the same age and the exact same phenotype. But if the drug is going to work, as we've seen in all drugs that have essentially been approved, right? They work in some, they don't work in others, even with identical phenotypes, I would argue. Children with Dravet with same mutation, same phenotype, one responds to valproate, the other does not.
Differently, sure.
So it's hard enough to get these trials going and enrolling. I just don't know if it adds additional power by homogenizing it even more. That's just a comment.
Okay, thank you, thank you. Francesca? No.
No, scusate.
Apologies. Just to say that it would be great to have a trial with children of the same age and the same phenotype, but our numbers are what they are in terms of number of patients. I mean, there are 50 in Italy, and you know what I mean? I don't know. How could we do that? I mean, how could we perform a trial? First of all, we need the family consent, and not everybody is willing to participate in a trial. And then please also consider that you need, of course, a meaningful frequency of the seizures, and this is not the case for all the girls. If we now start searching even for the same age and the same phenotype, we will never be able to run this trial. Now, be careful. What we are discussing here is, I would say, slightly more ideal, meaning what is the best condition to study a drug, a medication. Of course, in practice, this is a rare disease, a rare condition, and it is not always possible to get the ideal situation to study a medication. We're not saying that from now on we don't want to run any trials, or we do not recommend trials which are not homogeneous. We're just saying that if we want our results to be more reliable, then it would be advisable to stratify the results according not only to the number of seizures in general, but also according to other factors such as age or type of frequency of seizure. Do you understand? It depends on how accurate the trial is. So maybe you have to evaluate it ex post. But what if in our trial we have 20 patients? 4 patients are, say, from 0 to 6 years old, and the others from 6 to 12, and so on. It's going to be very difficult to have reliable data in terms of stratification. We will have data that are reliable in the widest sense of the word. But then, of course, there can be a bias. This is what we meant. Here is my comment. Maybe it also depends on the type of medication that we're testing, meaning that if it's a targeted treatment, its pathogenetic mechanism is a specific one. Well, in that case, we might expand the criteria. I mean, just to give you an example, if you're testing ideally a new channel blocking agent, and you enroll patients who have a mutation in that channel, of course, age changes, of course, the onset may vary, but you may also redesign and reevaluate the elements at the end of the trial. While this morning we heard about specific molecules, or as Professor Vigevano said, if you are working on an anti-inflammatory agent, an anti-inflammatory agent works well during a seizure because it is well known that during the seizures, the central nervous system increases gene expression involved in the inflammatory process, while the expression of the adhesion molecules goes down. And since we're testing a product, an agent that is a wide spectrum one, well, then the enrollment of the patient has to be more stringent, or at least we should evaluate our criteria accordingly. Maybe what I said is silly, the speaker said. Professor Della Bernardina? No, it's me. Well, I believe. Well, then, Professor Della Bernardina. Professor Della Bernardina. Professor Della Bernardina said very consistent and wise things talking about the clinical features of a trial. But let me share my comments with you. I believe that enlarging the number of patients available, having a heterogeneous group of patients, and this is my point of view, having instruments that allow us to carry out an early diagnosis, including children at a younger age, this is going to help us, provided that the clinical trials are designed in a way that is clinically stratified and consistent. This is going to give us more opportunities in following the effect of the medications and in evaluating the actual efficacy. And then, of course, much depends on the type of medication. But at least we need to have a clear understanding of the biological action of the medication. And we also need to have a wide range of children's age. I think this is going to render our conclusions stronger. It will help us in evaluating the pharmacology. What you said is perfectly true, but we should not confine ourselves. We should not, run trials that are completely blinded. These are neurodevelopmental diseases, and this is how they should be seen and interpreted. You have to evaluate your patients at a very early stage, and then you will also evaluate them in the long term, because they might not be primary, as in the case of epilepsy.
Okay.
Maybe one last comment that'll transition this to a different topic, but Jack mentioned precision medicine, right? The value in phenotyping is to better understand the genetic etiology for new genetic discoveries, so that through various models, whether it be iPSCs or zebrafish or what it may be, we can then massively screen compounds that we have no hypothesis whatsoever should work for seizures. And I see that as the move forward, to find a compound by accident, because thus far our rational design and rational hypotheses have failed us in terms of treating epilepsy. We are more than just an ion channel, right? So all we have is channel blockers. So we clearly need something more than that.
Someone else?
I just wanted to give you food for thought. This is the only way out. The clinicians, the sponsors, and the associations of families, the family associations, together should invent a strategy to modify the trials in time. I'm not saying that you cannot run a trial if you only have 50 subjects. I'm not saying you don't have to include other subjects. You just have to be aware of the fact that you have a trial in which you have 150 people with 4 different things, and then you have to verify whether the X and Y product may be effective in those patients. And you have to give evidence that it is potentially effective. But you also know that you have no clear indications. You don't know if that's suitable for a specific case. And that's where you need a larger number and relatively fewer clinical data. These are the kind of trials that are becoming more common nowadays. Recruitment is made by obtaining clinical information from the families. All we have is what we get from the families. You know, this is helpful, But you also know that this cannot be used in other cases. So you have two options. Either you run very large trials and perform analysis of several data that you may need in the future. So it's not enough to know whether she has seizures. You also need to know, do they take place during the day, at night, how many, 10 in 1 week, 10 in 1 month? And what about the seizures that are only recorded by the EEG? Are there any seizures you can be aware of by simply looking at the subject? And as you will understand, the trial will be very complex and very expensive in such a case. And then very few centers would be able to run such a trial. Or, as an option, you may want to first run a trial, and this is the kind of trials that we run, knowing that eventually you will need strategies, marketing strategies, health policy strategies, organization strategies, etc., whereby there can be open trials that will verify a set of things. So it's not enough to demonstrate that a drug can be helpful. You also have to give evidence. You have to demonstrate who can benefit from it and who will not benefit as much. I hope I made myself clear, the speaker is saying. So it's a matter of choice. You have to choose a strategy, decide on your investments, and this doesn't mean that you don't have to study certain topics, which is what we're doing nowadays. You simply need to know that in an open study and in the long term, with the support of the families and also with some financial support, we might be able to understand those who actually benefit from those treatments and those patients who don't benefit from these treatments. Stefano? Thank you. Thank you, Nicola. In addition to what Professor Della Bernardina said, let me add that not only do we have blinded or unblinded trials, we need to differentiate between trials that are properly carried out and trials that are not properly carried out. You want a trial not to be ambiguous when it comes to its objective. The objective must be clear, and the objective are seizures. Seizures associated with a specific medical condition, behaviors in a specific condition, or the quality of life of the patient. It is only by having the objective clear in our mind that the data will be easy to understand. If the trial is carried out to evaluate the reduction in the number of seizures, any additional information will not be the primary outcome of the trial. This is why it is paramount for the trial to be consistent, that the results we want to achieve is consistent with the objective that we originally set. And in this framework, there are no blinded or unblinded trials, but simply trials with objectives and hypotheses to be verified, which must be verified in that framework. And any additional outcome might be misleading when interpreting and extrapolating the data. Thank you. Now, just a few more minutes to the discussion, and then we'll open up to the families. I would like to discuss another topic. Maybe we did not dwell on that. Maybe we just mentioned it. It was just mentioned by Dr. Leguern. Talking about genetic counseling.
The genetic counseling is very complex for PCDH19 disease. Indeed, this mode of inheritance is very particular because it's an X-linked mode of inheritance, but male can be healthy transmitter and females are affected. And you have also the problem of sporadic cases. So I think that This is why I said that it's very important that the parents have to be followed by a geneticist, and this is very important for genetic counseling, and for also the possibility of prenatal diagnosis when they have de novo cases. And I think that the first step before the genetic counseling is the characterization of the mutation. This is why I think it's very important, when the phenotype is compatible, to perform molecular diagnosis and to provide some unambiguous results. And I would like to underline that in some cases, with missense mutations, we have this problem of interpretation. And this is why I think that in this case, it will be very important to build, to construct functional assay, to validate, to incriminate, to firmly incriminate the missense mutations. Indeed, we have some variants, and with these variants, we don't know whether this variant is a causative mutation or not. So I think that in the next future, we can organize the strategy for molecular diagnosis with a first step of sequencing with the new tools as the panel, the gene panels, which are very efficient. For example, in our laboratory, we design a gene panel including about 65 genes corresponding to genes involved in epileptic encephalopathies, including, for example, SN1A for the Dravet syndrome and also PCDH19. So with this panel, we can provide the positive results in a larger population than with the Sanger technique. And we can also, as Alessandra said, we can also detect the mosaicism, because we can sequence the same fragment with a very, very profound depth. And this is why I think that the genetic counseling will be also modified by these new technologies. And in a second step, from a small set of missense mutations, we need to develop functional assay. And this functional assay will be completely included in the diagnosis strategy. And for example, we discussed with Joseph about the estradiol test for PCDH19 mutations. And Joseph, you can comment what I said, but it's possible to distinguish between true mutations and polymorphism. And I think that this type of functional assay will be very important.
Yes, just want to comment on this. I'm just a little bit afraid about the genetic counseling and the prenatal diagnosis in a condition in which we don't know which will be the disease course of the disease.
It's impossible.
Yeah,
sure.
So I'm quite worried about the prenatal diagnosis in such conditions.
The prenatal diagnosis in PCDH19 related epilepsy is due to the existence of mosaicism in parents. That means that, for example, a subset of spermatozoids have the mutation. This is why the risk of recurrence is not equal to 0. So there is a risk. So in this context, the geneticist can provide to the couple, to the parents, can provide a prenatal diagnosis. And this prenatal diagnosis is particular because in this case, you will confirm that the fetus will not develop the disease. You don't have a 50% of risk. You only have a 5 or 10% of risk, depending on the proportion of spermatozoid which are affected by the mutation. So we can say that it will be possible in the next future to dose in sperm the proportion of mutation, but it will not be possible in female if the mosaicism is in the mother, you know?
Thank you. Joseph, would you like to comment on... Marina, scusa. Non si vede niente.
Sì, ho cambiato posto. Volevo sapere cosa ne pensava.
So let me know what do you think about penetrance, and as a consequence, I'd like to know what do you think of the female patients that have been considered to be asymptomatic.
Penetrance is the great problem of the dominant diseases, X-linked diseases, but also autosomal dominant diseases. And in autosomal disease, we speculate that other genes can determine the severity of the disease in interaction with the major mutations. But the situation is more complex in PCDH19. Maybe these modifying genes can exist. But in this context, we have also the variability of the distribution of X inactivation in the brain of the female patients with the mutation in PCDH19. So maybe, it's my hypothesis, we have both the action of modifying genes and also the problem of X inactivations.
Yeah, I would like to comment on some of these points of this discussion, and something which we really haven't discussed, we've only touched on, but I would say we need to agree to do, and that is what Joe started to do, that we started to do. We need to have a unified register of mutations, penetrance, and at least basic clinical presentations. This is a must, and I think we almost need to agree to it today, because it's an opportunity. We have the people here. We need to sort of pull down the international boundaries and dry the oceans, so we are all on one island, and that's the island of PCDH19. Because as you raised the question of genetic counseling, we don't know what the penetrance is. We're just guessing. We don't know how many women there are which have PCDH19 variants and which variants and are not affected. We need to put this information together in one place. And sooner the better. It's going to be extremely useful for any company running any clinical trial, because it's going to be the one-door entry into this disorder. And it's going to be actionable and quick if we want to move. Families, they're going to benefit from it, but of course they need to consent to some of that information to be shared. And we need to agree to take initiative. In terms of the classification of the variants, I just can comment that we have tested about 20. We tested frequent variants, we tested rare variants, and I'm fairly sure to say, I haven't presented the data, but estrogen receptor functional assay can distinguish the variants which are likely causative and variants which are just not damaging DNA variation. So we are confident that the test might be robust enough, but it's going to be fully robust, 100%, well, we can't say, because we need to develop another complementary test to ask the question. But so we may have that, so we will be able even to say that which variation is likely causative and not. There might be at threshold level, so maybe some mutations are not going to be as deleterious as the others. And we have not necessarily considered that. Our data show that they all behave potentially as a complete loss, but it may not necessarily be true.
Do you have the results, the correlation between the stop mutation and the missense mutation?
Some missense mutations behave like wild type. Some missense mutations behave in between the stop and
I think it's very important.
And the variation. So it's not very straightforward, but I think that information and technologies together with the collection of the data on mutations, patients, penetrance will make the counseling better, which make us really look at the incidence of this better and estimate that. We'll be better in estimating penetrates, and of course we will have a cohort ready for companies who will be interested to really do sensible clinical trials. So I think it would be good to somehow agree on that, how we go about it, at least in principle, and then just do it.
Thank you, Joseph. I think I agree with Registrar. I agree with most of what you say, and I think we should discuss about this. We should discuss very deeply. Thank you. Okay, Pasquale. Io direi dopo.
I'd say that after the question of Pasquale, I'd like to pass the floor to families. I'll give them the mic. Thank you, Nicola. Yes, I'd like to go back to one aspect which I believe is really interesting from the clinical point of view. I'm talking of the storm of crisis, which is connected to the fever episodes. As Professor Dalla Bernardina was yesterday saying, the sensitivity to fever is a characteristic which is somehow common, but it comes with different characteristics. And we know that the gradient, the body gradient, is what determines the crisis. And we know that the speed at which and with which the increase of body temperature is what triggers the seizures. And I'm thinking of drugs and anhydrous. But here in the intercurrent disease per se may be lasting days, for days. Now, out of the data that were presented this morning, very interesting ones, I could not get extra information, additional information as to the cause of all this. And obviously this is not just speculative, because if we could only prove that there is a movement or a shift of inflammatory molecules, then we could hypothesize corticosteroids, and maybe I'm being provocative, but maybe even immunoglobulin intravenously. Immunoglobulins, yes. IV. I agree. We don't have data. That's true. So what I can say, thinking of our own experience, is that some of these girls in past years were given diagnosis of encephalopathy, which was probably immune-mediated, because we did notice that some of them were showing an intrathecal band, a minimum synthesis intrathecal band. Some of them had some self-antibodies. And there was even a girl who had a significant improvement, a reduction of the hospitalization days with a cycle of gamma globulin that she received for almost a year. And I'm referring back to the year 2003 or maybe 2004. I don't remember, maybe even 2005. I don't remember exactly. So at that time, protocadrin did not exist at all. Wasn't even looming large. There was an impression at that time. The impression was that something could trigger the seizures. And that something was due to the increase of pro-inflammatory elements, interleukins, cytokines, maybe. Now, apart from the things that we had observed earlier on in the clinical practice, no one, and I believe that there is nothing in literature with this respect, no one has been studying the aspects that are pretty much immunological or maybe inflammatory that are typical of these patients. Honestly, I wouldn't know what to answer. Tiziana, do you have an idea about this? Have you got any ideas? Have you ever been studying with your patients such things? I'm going to sort of repeat what we said yesterday when we were working in groups, i.e., in epilepsy terms with the critical frequency, there is an activation of pro-inflammatory mechanisms. I believe that this is by now ascertained, and that the epilepsy comes with a different genesis. There may be malformation pictures, mesial temporal sclerosis, tuberous sclerosis are bringing about the activation of pro and anti-inflammatory molecules, because I believe that there is also a balance problem, which needs to be ascertained. And there may be reports that are not correct, that are not always replicated of cytokines, interleukin-6 maybe in particular. I think that the IL-6 is probably the easiest one to study, and that they exist in all sorts of epilepsies, generalized convulsive syndromes, West syndrome epilepsies. I believe that all of these observations and reports seem to confirm that there is an activation of the inflammatory cascade, maybe not in the induction direction, but rather in the sustaining of the mechanism of the epilepsy. So the use of steroid in this case could prove useful as a coadjuvant in the short term. And in this sense, immune globulins, which were historically used in different forms of epilepsy, and I believe that they were used many years ago, and that was a discovery made just by chance, as always is the case even in the epilepsy field. So the rationale of the use of immune globulin maybe today is more visible, because they tend to modulate and they tend to intervene. So modulating is the adaptive thing. So in the conditions that are primarily immune-mediated, but also in conditions where there is an activation of the innate activity of the brain activities, which may bring about any such effects. So there is an efficacy which is not specific of this or any other disease, a generic efficacy on a mechanism which is a maintenance mechanism, epileptic or epilepsy maintenance mechanism. Now, I don't know whether in this case, with this epilepsy, there is a more selective involvement of some mediators of inflammation. I don't know. Maybe I would even be surprised if I find one, if I did find one. Maybe sometimes if you look for something, then you find it. Maybe the more you dig and the more you find. I don't know. Tiziana, forgive me the question. What would then be useful to look for? Because in the PCDH19 girl, with the difference to the Dravet girls, there seems to be a susceptibility to fever. This is something different from the febrile status of a general disease. What is it that we should be looking for? Because what you are saying is true, but I do remember that many years ago, probably it was back into the 80s, as far as the Lennox-Gastaut syndromes, but also in the different epilepsies, that is drug-resistant epilepsies with polymorphic crisis. The first to do so was the French group in Marseille that were using immunoglobulins. And I think that there were even results that were published which were not that much brilliant. But what I am asking you, since you are the expert, an expert at least as far as immune-mediated diseases, since you've been involved also with the anti-NMDA encephalitis, there must be a self-maintaining mechanism, so much so that one of the last articles on the ketogenic diet is not talking about ketosis or its success, but rather the fact that this diet entails an anti-inflammatory mechanism as far as epilepsies are concerned. So what should we be doing more than that? In order to understand the mechanism of immunitary mechanism, what can we do more than that in order to understand how much the inflammation is involved? The in vivo markers are difficult because they are very susceptible to the temperature, to the time at which the withdrawal has been made. The peripheral ones do not match the central ones. The liquid dosing is not validated, so on and so forth. So this is a big, big problem. Even the imaging is a big problem. There are some imaging studies, even the PET resonance studies that seem to point at the activation of the microglial activation. But I don't know. From the clinical study viewpoint, I don't know what can be done, because this is a topic which is very much committing, hard to evaluate. The studies that are being made on the liquor and on the serum are hardly replicated by other groups of scholars. So there seems to be a limit in terms of methodology, at least. Methods are involved. And there may be other studies on tissues. I don't know whether, for example, a tissue, especially with respect to an animal model, could entail something like that. And I wonder whether this is possible, but I think it's hardly possible on human tissues. Nicola, is there anyone who now has some available animal model as far as the PCDH19 is concerned? Worldwide, huh? Is there anyone in the world? Yes, obviously there is one, more than once. In the first place, we have to evaluate how much fever, not the cause of fever, but fever itself may induce the cluster and the seizures, which is what's been done in the mouse model of the Dravet. Let's consider the mouse, take it, raise the body temperature, and see whether it develops seizures. And that is a way to see whether the increase in the body temperature and not the cause for that increase, which is what facilitates the seizures. So the first step would be the one of understanding, since the Dravet entails the elevation of temperature, or if then it's not, then it...
Allora, Nicola, hai sentito cosa ti ha risposto?
Nicola, I wonder whether you heard what he answered. So what he answered, Nicola, is that if in the PCDH they get fever, then they don't develop any seizures. Maybe the point needs to be better detailed.
Model of the with the mutation, do it has the same or similar phenotype that in humans, or yeah, that's why I knew that, but I don't want to say. I wanted that he told to us. Il problema è che l'animale mutato non ha nessun fenotipo.
The animal has no phenotype if it has undergone a mutation. What do you mean? It means it has the mutation, but no epileptic seizures, nothing else. Never, ever? So the animal has gone through a mutation, but it cannot be considered as a human being that has undergone a mutation, because it has no phenotype, it develops no disease.
Has no seizures and nothing at all, or he has a behavioral and cognitive impairment, this model? Ok. So avrebbe una frazione.
a fraction of the phenotype. It's not a nice model. It would not be a nice model. I thank all the participants, and now I would like to give the floor to the families, because of course it is their moment now. Any questions from the families? In the microphone, please. Hello. I'm very nervous, and I may break down from one moment to another. I'm a carrier mother. I'm a carrier of PCDH19. My daughter, she is 4 years old, and she has exactly my same mutation. I'm healthy. I've never had a seizure in my life. I have no intellectual delays, and my daughter does have this problem. So in my opinion, the research should try and understand how come that asymptomatic carrier mothers are different from their daughters who are symptomatic. I think this has not been discussed today. As a mother, especially as a mother, I would like to know why she has the problem, I don't. And I think that would be essential for research. I mean, understanding whether certain patients, girls with PCDH19, not asymptomatic, have features which in a way protect them. And the same features are not present in girls who suffer from this PCDH19 mutation and show the disease. This is the first point. The second point is the clinical side that I think was a bit missing today. As a parent, of course, research is interesting, genetic, molecular research is essential, but I need some clinical information. My daughter is 4 years old, and the manifestation of PCDH19 may vary a lot, but I would like to know, how could she evolve? What is going to happen when she becomes an adult woman? I don't think in literature this study has ever been made. Maybe I've found just a couple of them in the web, and I have never been able to go back to that study again. I think it was just one study carried out in the UK. Next time, I hope we're going to have another conference like this one, because it was very interesting. I would like to listen to the clinicians. What do they have to say? Because for the parents, because we experience the problem on a daily basis. We experience PCDH19 on a daily basis. We're entitled to know. It is our right to know. Thank you for your contribution. I can answer from my side, and then, of course, feel free to add your comment, your clinical comments or comments as clinicians. And then talking about the phenotype difference, I will ask the geneticist to take the floor. Now, as far as the future is concerned, well, your daughter, what is going to happen in the future? Well, of course, nobody can say, and especially because we have never seen your daughter. So it is only your doctor, your neurologist, who knows her history, who knows everything. Maybe he's the only one who can give you some information, but very general information, because to date, we still know nothing about the prognosis. There are factors which we assume. There are some factors which may help us in understanding whether the disease is going to evolve to a more severe or less severe form, but they are just hypotheses. So I cannot answer your question. The data we have, the clinical data we have, are not enough to answer your question. We can give specific answers on a case-by-case basis. I don't know if the other clinicians would like to comment on that. And as far as the genetic component is concerned, anybody who's willing to take the floor and express an opinion? Joseph?
You are asking very important questions, and we didn't discuss it probably because we either didn't have time or don't have good answers. So your first question, why we see these mom-daughter discordance or grandmother-granddaughter, we see it like that as well, that it goes through the father and then it goes back to the daughter, and the granddaughter is severely affected and the grandmother is very good. We have about 5 or 6 pairs like this, thanks to the foundation here and other people like you, which we study. I fully agree, it's an opportunity to look what makes it better or what makes it worse. So we do study that, but I really can't tell you that it's something obvious there. Clearly there are 2 explanations, 1 or 3. 1, that there is another gene which complicates it, another bad mutation somewhere, which makes it different, because we all have about 30 to 50 de novo mutations in our genes, which our parents don't have. One of these mutations is usually in a coding sequence, which makes a problem. So we all have them, and it can be just a bad luck that somebody will have 2 different mutations which can cause bigger problem. So that's the answer to your question. So we study it. There's not many cases like that, but hopefully there will be more, and that's why I think we need to have a register where this can be identified and we can study it more systematically rather than one by one. Your other question is about the future. Now, I see it like that. We found a gene based on large families because that's what we study. We study 7, 8 families across many generations. So because there were families, these women were not affected severely. They had some seizures when they were young, but they grew up and they were mothers. They look after their children and they lived pretty much ordinary life like many of us do. But then the French, of course, Eric and Christelle and the others, they found the more severe extreme. And of course, these girls are unlikely to become mothers, or less likely, perhaps, say it that way. And with them, the mutations will go and they are replenished by de novo events. So there is something which probably we can predict if we go back into histories of these familial cases to see why they're different and how they're different. But it looks like we have 2 extremes. We have those very severe cases which are always de novo. And then we have those familial cases which sometimes we probably don't even diagnose because they don't come to the clinic. They have 1, 2 seizures. So this is the challenge what Eric was talking about, what Nicola started about, the counseling. It's so important question. We can't do prenatal diagnosis simply based on mutations because we don't know the outcome. That will be wrong. But of course you would like to know what's ahead of you for your daughter. And here it's very difficult to predict. But generally I think we discussed it in San Francisco to some extent, is really the earlier onset of the seizures make it a little bit worse. So in a way the early development, and that's what Nicola said really, that your doctor should be able, based on the knowledge of your daughter and how the disease presents, to some extent predict where it's going to go. I think now it's probably enough number of cases. There's not an easy explanation, but we start build it. And again, to have a good register with good information and contacts to the relevant people would greatly help. Stop there.
Alessandra.
Just a comment. The explanations given by Professor Getz are obviously perfect. And then there is also the chromosome X inactivation that we mentioned this morning on several occasions. Maybe we did not highlight the concept enough. Now, the difference between chromosome X inactivation in the central nervous system might modulate the expression of the gene. We can test that only in the blood, and we cannot get to the chromosome X inactivation. We don't know what happens in the central nervous system, and this is what might modulate the presentation of the seizures and manifestation of seizures. We might study that with induced pluripotent stem cells. Of course, it's expensive. And anytime we try and write a project and we say we want to study methylation of the X chromosome, the expression of PCDH19 in relation to chromosome X methylation, we try and go to the root of the problem. Anytime we try and do that, anytime we try and understand the inheritance, the project is always failed and rejected, because they say that's a base project, it's not a treatment-oriented. Of course, it's more appealing for them to fund a project that validates medications rather than a project that tries and understand the cause of the problem, because they believe we are moving away from the therapeutical approach. In fact, in my opinion, this could be very helpful to devise a new treatment. And the second comment is that the gene was characterized and discovered by Professor Goetz only that was just in 2009. And then we analyzed some retrospective cases at my hospital, and we diagnosed one of Nicola's patients who's now 35 years old. Dr. Cusmai was talking about a problem. Now, looking at that patient and saying, my daughter is going to be like that, that's not possible, because, Nicola, correct me if I'm wrong, the pharmaceutical approach 30 or 40 years ago is completely different from today's therapeutical approach. And it cannot be predictive of the evolution of a patient who suffers from PCDH19. A patient who's diagnosed today is different from a patient who was diagnosed, say, 30 years ago. Or rather, a patient who had an onset 40 years ago and a patient who has an onset today, they're very different. I'm the father of a 19-year-old girl who was diagnosed 3 years ago. 3 years ago, in Verona, they diagnosed this syndrome, the syndrome we are discussing today. My question may sound trivial. She is my only daughter. Do you think, would you be able to estimate, I mean, would it be possible for me to have another daughter suffering from the same syndrome? Are there any cases in literature? What is the probability of me having another daughter like her?
You can see that the problem of genetic counseling is very complex, as I said.
I see.
It's the only affected female in your family.
Allora, se devo dire...
If I have to tell you the whole story, I have a sister, an older sister. She is 3 years older than me. And back when she was 11 months old, she had a very long seizure, and she was diagnosed encephalopathy. This was back in the 60s of last century. And now, from the neurological point of view, she is in a very difficult situation. 3 years ago, she underwent blood tests, and she tested positive for PCDH19. So do you mean that your sister has the same mutation? Yes, but she's much worse than my daughter. So your sister has a mutation, and your daughter has a mutation, and I'm the healthy carrier. And that's not the end of the story. My mother and I have no relations with her whatsoever, but based on what I know, one of her sisters died, maybe for neurological reasons, and they assume she might have suffered from a disease that is very similar to the one we're discussing today. So my question is, what if my daughter in the future is going to get pregnant and she had a girl? Would there be a high probability, a high likelihood for her daughter to be born with this mutation?
I think that we can design the pedigree, and we can say that it's familial forms with a transmission of a mutation. But we have always this problem of penetrance, and your family is an example of this different expressivity of the phenotype. And this is why we discuss about the problematic of the genetic counseling, the place of the prenatal diagnosis in this disease with this very large variability of the phenotype. And I think that you have to go in a genetic counseling service, because it's difficult in this audience to give you an answer. But when we design the pedigree of your family, it's a transmission of the mutation. Did you perform the test?
Yeah. Myself, yes.
Yes.
It's positive.
Positive.
He is carrier.
So we know, we can perform a diagnosis. We can know in your family who is carrier or not. But as we said for a long time, we cannot prognose the severity of the phenotype. It's impossible. It can be due to the type of mutation, but in your family, all individuals, all females have the same mutations, and they have different phenotypes. So this is why we think that another event or another genes can interact with the major mutations to determine the phenotype. And you have also the possibility of a variability of the distribution of X inactivation in the brain of the different females in your family, determining the epilepsy and also the behavioral abnormalities. Do you understand what I said?
Yes, a little, more or less.
More or less. So I think that you have to go to the department.
Genetic counseling.
Yeah, genetic counseling, because it's very important.
But are there the case where are two sisters that are both affected from PCDH19? Ci sono?
I didn't catch qual era la domanda.
No, chiedevo appunto se ci sono in letteratura.
I was asking, are there in literature any other cases of sisters, both of them suffering from a PCDH19 mutation? Sure. The answer is yes. And there are also cases of 3 sisters, all of them suffering from this mutation. Dr. Granata has just left, but she's following 3 sisters. With a different presentation. I would like to ask, one of the afternoon speakers mentioned the possibility for girls suffering from the PCDH19 mutation, the possibility for them to develop neuropathies. Is that right? Is this what you mean? And what does that imply exactly? Who said that?
Chi l'ha detto?
Who talked?
Joe. What about peripheral neuropathy?
Joe, was it you? Did you talk about peripheral neuropathies? I was told Dr. Getz, when he was talking about the period after menopause. Well, that's better then.
I feel, and please disagree with me if I'm wrong, we can maybe give some numbers to this gentleman in terms of, because it doesn't sound like you've been given numbers in terms of risk of passing on the mutation, which would be important for you to know, right? So does one of the geneticists want to do that? Or I'm happy to do it as a clinician. But because you have the mutation, if you have another girl, there is a 50% chance, right, sorry.
Thank you for the clarification. Thank you.
You're going to do it better than I.
Sorry?
Because we should talk about multiple generations, so.
Yeah.
You want me to keep going?
Okay. Did you get?
You're on? Okay. So yes, if you have another daughter, she will have the mutation. The question is whether or not the severity or whether or not she is symptomatic at all. Then it's equally important to know that your current daughter and what she will pass on to her daughter has a 50% chance of having a daughter with a mutation. And if she has a son, that son has a 100% chance of getting the mutation, but would then most likely be an asymptomatic carrier, which would then affect the counseling for his children. So it is very multi-generational.
Let's make an assumption. My mother, she had a brother, my uncle, who died. My uncle had 2 sons, okay? My question is, genetically, from the inheritance point of view, this potential transmission, so 2 sons, no girls, so I don't know whether my uncle was a carrier or not of this mutation. We don't know because of course, my mother did not test, for example. So my question is, this potential inheritance and transmission of the mutation in my 2 cousins, male cousins, was it interrupted? Unfortunately, comments are being made out of the microphone and we cannot translate. Yes, the possibility of transmission stopped because your uncle had a mutation of chromosome X. He passed chromosome Y to his sons, so that branch of the family is risk-free. The risk is still in you. You might have affected daughters, and your daughter has a 50% probability to have girls who might present the mutation. The genotype is clear. The risk of the genotype is 50%. The phenotype cannot be foreseen. Questions? Francesca? Comments? Maybe we have to draw some conclusions. Unless you have any questions, we can close the meeting. Well, I hope. Why don't you come on stage? Please do come on stage. I hope you will take up this suggestion, this advice. As I said, I hope you're going to take up the recommendation to carry out a serious collection, a serious data collection on mutations, seizures in the girls. Let's try and understand. Today we know more than in the past. We need to collect data in a very accurate way. And we have always been telling you, we are in your hands. We know you do that. We know you do that, but of course, you need to compare your data with the data collected by other centers. Maybe this is still missing. We're doing our best. We keep encouraging you, we keep pushing you, and we'll keep on doing that. Thank you.
Sorry, I just wanted to make one other comment and advertisement. We will be holding a similar conference next year in San Francisco. And Francesca, I'm not sure if the families all have your contact information, but we, from a planning perspective, would really appreciate families' requests for topics that could be discussed. It's going to be made available on the internet next year, so you could log in and watch it live. And so we are right now in the process of setting the agenda. So any topics that you would find interesting, please let Francesca know, and she could pass them on to me to make it to make these conferences continue to get better and better. So
thank you. Chiudi tu, Francesca, ma io prima che tu chiuda.
Francesca, before you officially close the meeting, I would like to thank you all.
Much my colleague here, Dr. Higurashi, Dr. Leguern, and I would like to thank you, Joseph Gates, Joe Sullivan, Giuseppe Biagini, and every other person that came here and gave the contribution to this very helpful discussion on PCDH19 condition. Grazie a tutti e soprattutto grazie.
Thank you everybody, and we especially thank the families, the association, that they have given us the possibility to be convened here to discuss this topic. Thank you and goodbye.
Pasquale, anche a te, grazie. Scusa.
Pasquale, thank you very much. I always see you, that's why I didn't thank you. So goodbye. Goodbye. Thank you very much, and thank you for participating. Our conference is going to take place in 2 years from now. So let's stay in touch. And we are very grateful to Professor Sullivan. We'll give our own contribution to the San Francisco conference agenda. And let's keep in touch, and let's do our part. Because if we join forces, we can be stronger, now more than ever.